Hey everyone, if you're a nursing student getting ready for your OB rotation or you're deep in the trenches of NCLEX prep, then you are in the right place. We are about to build the ultimate study guide for postpartum infections, covering everything you absolutely need to know for your exams and, more importantly, for your future patients.
So here's our game plan for today. We're going to start with the basics, the absolute must-know foundation. Then we'll dive deep into the big three infections, uterine, breast, and urinary tract. And finally, we'll put all that knowledge to the test with some NCLEX-style practice and a case scenario to really get your clinical judgment skills firing. Ready? Let's do this.
All right, let's jump right into Section 1. What are postpartum infections? Before we can even think about treating these, we've got to know exactly what we're looking for. Getting this foundation right is absolutely key.
Okay, so what's the official definition? A postpartum infection is any infection that pops up within 28 days after a delivery or an abortion. And the big thing to remember here is that it can show up in a few different places: the uterus, a C-section incision, the breast, or the bladder. This is exactly why your head-to-toe postpartum assessments are so incredibly important.
If you burn one thing into your memory from this whole session, let it be this number: 38 degrees Celsius or 104 Fahrenheit. A fever that hits this number or goes higher after the first 24 hours postpartum, that is the number one giant, flashing red light for an infection. And this isn't just a simple fever. It's a serious warning sign for septicemia, which can be life-threatening.
Okay, so we've got our universal warning sign down. Now, let's zoom in on our first major category, uterine and wound infections. Honestly, these are the most common ones you'll see, and being able to tell them apart is a critical skill.
We'll start with the most frequent offender of them all: endometritis. This is an infection of the endometrium, which is the lining of the uterus. And a key detail for your exams is that it often starts right at the spot where the placenta was attached. It's like the perfect entry point for bacteria. You'll usually see the signs for this show up around day 3 or 4 postpartum.
So you're probably wondering, how do these infections even get started? Well, think of each of these risk factors as an open door for bacteria. When the membranes rupture and labor is prolonged, that door to the uterus is left wide open for hours. If little pieces of the placenta are left behind, they basically become a food source for germs. And any procedure like a C-section or internal monitoring, that's a direct pathway, completely bypassing the body's natural defenses.
This right here is your clinical cheat sheet for telling these two infections apart. Let's really focus on the drainage. For endometritis, your biggest clue is going to be that foul-smelling, maybe even pus-like lochia. But for a wound infection, you're looking for local signs right at the incision. You'll see warmth, redness, and that surpurulent drainage. That's a thin, yellowish, pus-like fluid coming from the wound itself.
Okay, this is so important for your exams and for real life. When you suspect an infection, the order you do things in matters a lot. Notice, step 1, get cultures. You have to do this before starting antibiotics. Why? Because those antibiotics can totally mess with the culture results. We need to know exactly what bug we're fighting to pick the right weapon. Once those cultures are off to the lab, then we can start the broad-spectrum antibiotics, manage pain, and hammer home that crucial hygiene teaching.
All right, let's switch gears and move on to our next big topic: mastitis. This is an infection of the connective tissue in the breast. It's almost always unilateral, meaning it just affects one breast, and you'll see it most often in those first 6 weeks of breastfeeding.
The two main culprits here are milk stasis and nipple trauma. Think of it this way: milk that isn't moving becomes a perfect breeding ground for bacteria. And cracked or fissured nipples? That's like leaving the front door wide open for organisms like Staph aureus to waltz right into the breast tissue. Even something as simple as an underwire bra can cause problems by blocking a milk duct. So let's break down what the client tells you versus what you find on your own. They're going to report feeling like they have the flu, chills, body aches, and they'll point to a really painful hard spot on their breast. That's your subjective data. Then, your hands-on assessment, your objective data, will confirm it. You'll find a warm, red, swollen area, that telltale fever, and maybe even some swollen lymph nodes in their armpit on the affected side.
Okay, listen up, because if you remember one piece of patient education for mastitis, this is it. I know it sounds totally counterintuitive to tell someone to breastfeed from a painful, infected breast, but it is the single most important thing they can do. The goal is to empty that breast and get the milk flowing again. Emptying the breast is truly the key to getting better.
Next up, let's talk about postpartum UTIs. These are super common, often because of trauma to the bladder during delivery or from having a catheter. But we take them really seriously because an untreated UTI can travel up to the kidneys and cause pyelonephritis, which is a nasty kidney infection that can lead to permanent damage.
Looking at these risk factors, you start to see a theme, right? An epidural, for instance, can decrease the sensation to void, leading to urinary retention. And what happens when urine just sits there? It becomes a perfect swimming pool for bacteria. And, of course, a urinary catheter is basically a direct highway for germs to travel right into the bladder. The management plan here is pretty straightforward, but every step is vital. First, we confirm what we're dealing with by getting a clean catch urine sample. Then we start the antibiotics and get their discomfort under control. But a huge nursing intervention is pushing fluids. We want them drinking at least 3,000 milliliters a day to help flush all that bacteria out of their system. And, as always, we reinforce that crucial perineal hygiene.
All right, we have covered a ton of core content. Now let's switch gears and put on our NCLEX hats. This section is all about how you'll be tested on this information. It's about taking what you know and applying it to show your clinical judgment.
Okay, take a good look at this question. Read through all 4 options and think back to the risk factors we just discussed. Which one of these clients is at the greatest risk for an infection? Go ahead, take a moment to think it through.
The correct answer is B, and here's why this is a perfect example of an NCLEX question. Options A, C, and D are all major risk factors, but they're risk factors for postpartum hemorrhage. The NCLEX loves to throw in these distractors to see if you can differentiate between complications. Premature and prolonged rupture of membranes is the classic setup for an infection because it gives bacteria the most time and the best opportunity to travel up into the uterus.
Here's a quick memory trick for you. Mastitis is a super common topic on nursing exams, so to help you remember the key management points, just think of the word REST.
Let's break it down. R is for rest. The body needs energy to fight off an infection. E is for empty the breast. We've talked about how absolutely critical that is. S is for support. A good, well-fitting bra, but make sure there's no underwire. And T is for treatment. Manage the pain with analgesics, and most importantly, teach them to complete the entire course of antibiotics.
All right, let's wrap things up by putting this all into practice. This is our final section, a chance for you to synthesize everything we've talked about and apply it to a real-world scenario.
Okay, final challenge. Picture this. You're working the clinic phone line. It's postpartum day 4. A client who had a C-section calls in. She reports a fever of 38.5. Her uterus is tender to the touch, and she has foul-smelling lochia. She also says she's exhausted and has no appetite. Every single alarm bell for endometritis should be going off in your head. So, based on those findings, what is the nurse's priority action? What would you recognize? How would you analyze these cues? And what is the very first thing you would do?